Good morning, everyone. No voice. Youngsters. Good morning, everyone. Okay, myself, Dr. Saujanya, Assistant Professor, Department of Community Medicine, Sridevi Institute of Medical Sciences and Research Hospital. It's my pleasure to welcome you all to this grand occasion, the inauguration of second Cath Lab at Sridevi Institute of Medical Sciences and Research Hospital, Tumkur, as well as CME program on assessment and management of cardiovascular emergencies. This program is designed to benefit both healthcare professionals and the general public, enhancing the awareness and preparedness in handling critical cardiac emergencies. So, as you all know, that cardiovascular emergencies remaining a leading cause of morbidity and mortality worldwide. So, timely recognition and intervention can make a life-saving difference. Today's session aims to deepen our understanding of rapid assessment, early diagnosis, and evidence-based management, strategies for life-threatening conditions such as acute coronary syndrome, heart failure, arrhythmias, and many more. We are privileged to have distinguished speakers with us today. Dr. Deepak TG, Associate Professor, Department of Emergency Medicine. I welcome you, sir. Dr. Naveen, Professor, Department of General Medicine. Clap, guys. Dr. Suresh S., Intervention Cardiologist, Department of Cardiology, Assistant Professor in Department of General Medicine. Their expertise will provide us with practical approaches, recent advances, and key insights that are crucial for effective management of cardiovascular emergencies. So, before the inaugural ceremony, we will have two CME sessions. Once our chief guest arrives, we will proceed with the inauguration program, followed by a short break for a high tea. The final session of the CME, cardiovascular emergencies, that is cardiologist perspective, will be taken by this Dr. Suresh S. after a break. So now, without delaying further, let's begin our session. I invite Dr. Deepak TG, Professor, Department of Emergency Medicine, to deliver a talk on cardiovascular emergencies, what needs to be done in an emergency setup. So next we'll have a session on cardiovascular risk factors, primary and secondary management by Dr. Naveen, Professor, Department of General Medicine. Thank you.
So without wasting time, let me get started. I'm Dr. Deepak TG. Good morning, everyone. Good morning, everyone. Okay. So nice to hear good, the audience is, number of audience is very good. At least we can send the message accurately. So I think Madam has already told regarding what is the importance of having the CME on cardiovascular emergencies, because Madam has already spoken regarding the burden, the global burden, and the burden that is in India, especially in the recent times. So we are seeing a lot of cardiovascular emergencies which are coming to the hospital. And obviously, many of you might have experienced in your amongst your relatives or amongst your friends also. Lately, the cardiovascular emergencies are increasing in young, so that is even more alarming. So we have to learn what sort of cardiovascular emergencies come to the emergency setting, and how we manage such patients, how we identify, how we manage such patients. So today, in my session, we are going to learn about overview of clinically important cardiovascular emergencies. I'm not going to deal about all the cardiovascular emergencies, only a few of the cardiovascular emergencies that are important, especially the theme for the day is regarding the Cath Lab inauguration, right? So what are the cardiovascular emergencies which can be treated utilizing the Cath Lab by the interventional cardiologist? So, and I'm going to talk about the patient outcomes if we don't identify or if the patients don't come to the emergency setting early. So, and their clinical outcomes, adverse clinical outcomes, I'm going to talk about it. And I'm also going to talk about importance of timely intervention in emergency. So the first cardiovascular emergency, the most important cardiovascular emergencies I think most of you know about is acute coronary syndrome. In our days, those days, it used to be called as myocardial infarction. Nowadays, the names, the nomenclatures have changed. The newer nomenclatures are, these are again older nomenclatures like ST elevation MI, non-ST elevation MI, or unstable or stable angina. But lately, there are a few nomenclatures I think Dr. Suresh will be talking about. OMI and NOMI, that is obstructive myocardial infarction and non-obstructive myocardial ischemia. So those things I'm going to talk about, and I'm going to talk about acute limb ischemia, and also I'm going to talk about acute thromboembolism. So what we are going to talk is, what I'm going to talk, and I hope you understand, is regarding how we manage in emergency setting. That's it. So the rest of the topics will be dealt by the cardiologist. So what is acute coronary syndrome? Anyone in the audience? What is acute coronary syndrome? What do you understand by acute coronary syndrome? So there is blockage of blood flow to the heart, right? So that is secondary to either obstruction, thrombus, or spasm. So any blockage of a blood vessel in the heart, the coronary blood vessel in the heart, will lead to ischemia, or it can turn to infarction if it is not treated. So the spectrum of diseases vary from ST elevation, non-ST elevation, or unstable or stable angina. So I've already told regarding OMI and the rest of the, details of which Dr. Suresh will be talking. So how they present, these acute coronary syndromes, how they present to the emergency. So these patients, when they come to the emergency, they'll complain of chest pain. Some patients will complain of chest pain. Some patients will complain of burning sensation in the chest. Some patients will complain of some pressing sensation in the chest. There are many definitions according to the textbook. So obviously nothing is clear. So lately the American Heart Association have defined a patient who has any of these complaints as chest discomfort. So chest discomfort is the broadly used term that has to be utilized for any of these, either pressure symptoms or tightness or squeezing or heaviness or burning. So any of this, because many a times we go by the classic definition of acute coronary syndrome, the chest pain. So it may not be typical. So sometimes it will be varying. So you might think that it may not be related to the cardiac. It may not be cardiac origin. You may think that it is a non-cardiac origin. So we may miss out. So that is the reason why it has been very well defined by AHA that chest discomfort. It can be any of these symptoms. I want to emphasize this because here our UG students are there. So when you come to the clinical postings, obviously you will come to the emergency, you will come to the medicine or cardiology posting. So there you should see the patients with varying symptoms. Okay, it may not be just localized to one side. That is just retrosternal. It need not be. It can be on the right side. It can be on the left side, and it can be epigastric region. It can be on the back. It can be on the shoulder. There can be radiating symptoms. It may not be just limited to one place. It can be radiation. There can be radiation. You can see it on the picture. How the radiation usually it depends on the cardiac innervation. The pain is felt in different parts of the body, especially on the left side. It is usually on the left side, but still you can have. Patients can have radiation to the right side also, right shoulder also. So we should always be very suspicious when we get such patients with chest discomfort. There can be some patients, especially in patients with diabetes, if they have any neuropathy or any patients who do not have that much of pain, they will not reveal that they have pain. They'll come with other symptoms, other associated symptoms. They might come with shortness of breath. They might come with just nausea and vomiting, giddiness, and they may also come with acute onset sweating. So these will be the general complaints that patients present with. So these patients also, you should be very suspicious. You should always look for other clinical signs why the patient has these symptoms. Otherwise, again, the possibility of missing out uh, the acute coronary syndrome is very high. So that is the reason we always look at these symptoms, and also we should look at the risk factors. Does the patient have any diabetes, hypertension, smoking, or any other risk factors that I think Dr. Naveen sir will be talking about the risk factors in cardiovascular diseases. So when we get such patients, I'm just going to deal with acute coronary syndrome, but still, when we get a patient with chest discomfort, it need not be cardiac alone. Okay, so it can be a musculoskeletal issue, it can be a pulmonary issue, it can be any other. Okay, so for that reason, we have to always get an ECG when a patient comes with acute chest discomfort. So what is the ECG? I mean, what are you looking at the ECG? This is a normal ECG. I think those who have already completed the first year physiology, they would know what is normal ECG. Normal PQRS complex, the isoelectric line, where the ST segment is on the isoelectric line. So this is a normal ECG. What we should look at is there any changes in these electrical, recordings? See, you can see it on the left side of the slide. See, that is a normal morphology on the left, extreme left upper part. So the next is if there is any ischemia that is setting in, these patients will have hyperacute T waves. You can see the morphology of T wave in the first this one, right, image. So the next will be the patients will have hyperacute T waves. Many patients in the emergency, they'll come with acute chest pain. They need not have an ST elevation. We can just see if there is a hyperacute T waves. That is also indicative that these patients are at risk. These patients are at high risk, and they can go into ST elevation anytime. So that is an important aspect. We should identify that hyperacute T changes, and then we should look at ST elevation. If there is any patient who, obviously, if it is not identified early, hyperacute T changes, or if the patient's present late, so there can be ST elevation. You can see the ST segment is elevated from the isoelectric line, so compared to the normal ECG. Okay, then if the patients appear late in the emergency, there is already formation of Q wave. This is the Q wave. So this Q wave, if it's already forming, that indicates the patient's presentation is late. So there is already ST segment is coming down. Here also there is a possibility of the improvement of clinical symptoms. If the patient undergoes early percutaneous intervention. Otherwise, if they come with properly formed Q wave and then ST segment coming back to the baseline and then T wave inversion, the patient might have had an infarction which is irreversible. So it is important that we get any patients with first two, that hyperacute T wave or ST elevation, we should immediately be alerted. We should immediately alert the cardiologist, interventional cardiologist, and make sure that these patients undergo primary percutaneous intervention, because time is muscle. See, Dr. Suresh always speaks whenever he comes to the emergency. He talks about time is muscle. He's very particular. See, many guidelines suggest that the door to balloon time should be ideally within 90 minutes. But here in our hospital, it is even more, far less. It's usually 15 to 30 minutes max. So that importance is given for these if there is any ST elevation MI. So coming to a few of the ECGs that we see in the emergency. This is the ST elevation MI. You can see in the V2, V3, V4, there is ST elevation, right? You can see, right? ST elevation in V2, V3, V4. So that is indicative of anterior wall MI. I'm just showing you the ECG. There are certain blood vessels which are involved when you see an ST elevation in these patterns, V2, V3, V4, V1, V2, V3, V4. So you have to be alert whenever you find ST elevation. It need not be, you need not, in the emergency, we need not try to point out which vessel is involved. Yes, we have to know, but at least when you are working as an intern or you're starting your post-graduation, you see an ECG where there is an ST elevation, we should immediately alert the cardiologist for further intervention. So this is another ECG which shows the 1 and AVL. You can see the 1 and lead 1 and AVL. You can see the ST elevation, right? This corresponds to the lateral wall of the cardia. So if there is any ST elevation, so that again can result in the infarction. So this is anterolateral ST elevation MI. I'm just showing you the ECG. Obviously, you just look at the ST elevation where all you can see. So these ECGs are very, very obvious. Very, very obvious. You need not wait or you need not waste time alerting the cardiologist. So this is an inferior wall ST elevation MI. Got it? So if you find at the history level and if you So at the history level, if the patient is complaining of retrosternal discomfort, chest discomfort, and if you see a patient having ST elevation MI, so immediately there is no other investigation that is necessary in the emergency. These patients should directly go to the Cath Lab for intervention. Okay, but sometimes while going through, some patients might come with the ST elevation will not be obvious. You can see some ST depressions also. So what to do? These are all, there is no acute infarction that is already set in, but there is an underlying ischemia. These patients can also land up in infarction. So these are the set of patients which we tend to miss out in the emergency also. So if there is any obvious ST depression of more than 1 millimeter, 1 mm, that is one small square. If it is more than that depression, that also such patients with high risk factors should go for percutaneous intervention. Otherwise, again, if the patient's ST depression is not more than 1 mm, but the patient has the typical chest discomfort, in such patients, what we should do is we should next go for other further investigations. And also, sometimes we may see patients with some sort of dysrhythmias. We can see a patient with atrial flutter, SVT, prolonged, atrial fibrillation and other ECG changes. In such patients also, you should be very, these patients either have an infarction or an ischemia that has resulted in arrhythmia, or it can be some sort of a electrolyte or metabolic abnormality that would have resulted, right? So we should be very suspicious, because if it is an electrolyte or some sort of a metabolic abnormality, such patients will give us time. Otherwise, if it is an infarction, if it is because of the coronary blood flow, lack of coronary blood flow to the cardia, so these patients will not give time. They may land up in shock, cardiogenic shock, or patient can have cardiac arrest. And if not treated and if patient survives, they can have heart failure and further long-standing complications because of MI. Okay, so in case if it is inconclusive, ECG is not showing any ST elevation, just mild ST depression, or the patient has a normal ECG which is inconclusive, but the patient falls in intermediate risk. That I am going to talk about the risk stratification, how we are going to do. But if the patient falls in intermediate risk, such patients we should send for cardiac biomarkers. I think most of you know regarding the cardiac biomarkers that are used routinely, right? CKMB, creatinine kinase, and myoglobin and troponins, right? So you can see the graph. See, CKMB, the creatinine kinase and myoglobin are not specific, neither sensitive, but they are the first the markers that get elevated in the blood. You can see the graph, the blue line. See, these are the ones which get elevated within usually 30 minutes. These will be elevated. These isoforms, CKMB isoforms, will be elevated in the first 30 minutes itself. But we don't rely upon this. We rely upon more specific marker for cardiac. That is cardiac troponin. That is high sensitivity cardiac troponin. The red one, the red line that we see, that is the troponin. Usually it gets elevated over after 1 to 2 hours, and then peaks by the end of 24 hours, and gradually comes down to the baseline by about 6 to 7 days. So this is how we look at the cardiac biomarkers. We don't rely upon the CKMB. We always look for high sensitivity troponins. So this is the high sensitivity troponin. When we do a high sensitivity troponin, if it is normal, that is less than 5, and the patient is in low risk category, such patients can be discharged from the emergency. With obviously, we have to look for other causes of chest discomfort. It can be musculoskeletal or GI or respiratory. So we have to look into those things, and then we can plan to either discharge or uh, plan to treat the underlying other disorder. If the again we tend to get into dilemma when it is equivocal. It is on the upper normal range, or it is between 5 to 50. That is when we should be very careful. These patients are the one who we again tend to miss out. So such patients, if they fall into intermediate risk, such patients we should always repeat an ECG after about an hour to 2 hours, and then we should repeat the troponin. So this again, we will look at the serial troponin, so that if there is any serial troponin elevation also, any change in serial troponin also indicates there is an ongoing ischemia or an infarction of the myocardium. So this is something we should always be looking at. And if it is more than significantly elevated troponin, there's no doubt we just have to go for percutaneous intervention again. Got it? So when we have a lot of doubt regarding this one, with the history or ECG is not conclusive, again troponin is not conclusive, we look at the various scoring systems, risk stratification, to risk stratify the patient, whether to admit the patient or observe the patient, or we can discharge the patient. It depends on few of the risk scoring systems. That is one of the most common risk scoring that we use is heart pathway or gray scaling. So both of this, I'm not going to detail of it. So we can stratify them to either low risk, intermediate risk, or high risk. High risk patients should definitely be admitted. Should definitely be. These patients should undergo coronary angiogram. Whether there is any block or not, that can be. It can be a diagnostic coronary angiogram. But intermediate risk, these patients should be admitted to the ward, and then we should observe the patient and again repeat further investigations as necessary. So just to repeat again, if there is a ST elevation, what do we do? If there is a ST elevation MI, what do we do? If there is a ST elevation, what do we do? If there is an obvious ST elevation MI, what do we do? What do we do? Very good. Coronary angio, PCI. Okay. Then, if required, angioplasty has to be done. Obviously, these are second year students. So, are you understanding what I am speaking? I hope you are understanding. Okay. So, if the patient has an obvious ST elevation MI, they'll go for, if the patient is in acute chest pain, these patients will go for coronary angio. If the patient is in high risk category, again, not an obvious ECG showing ST elevation MI, again, these patients will go for coronary angio. If the patient is in intermediate risk, the risk factors are not very high risk, so such patients we can go for anatomical testing or functional testing using stress echo, TMT, and other investigations. So this is what we do in emergency for an acute coronary syndrome evaluation. So what are the medications that we give in emergency? See, these whatever MI patients will not give us time. These patients will have a lot many associated symptoms. So obviously, if there is a ST elevation MI, before the patient is shifted to the Cath Lab for PCI, we should always provide the patient with oxygen if it is less than 90% only. If it is more than 90%, no need for oxygen. We should provide the patient with analgesia. So these cardiac pains are usually visceral pain. Visceral pain, it is, the patient will respond only to the opioids like fentanyl or morphine. So we can give fentanyl or morphine to alleviate the pain, and then we start them on aspirin. This is the class 1 recommendation. Any MI, NSTEMI, you have a doubtful high risk category, these patients should receive antiplatelets. Antiplatelets, one of the most common antiplatelet that we use is it is always advocated dual antiplatelet. One of the most common antiplatelet, one of the antiplatelet that is mandatorily used is aspirin. I think the second year students, you are going to undergo classes, pharmacology classes. There you will start understanding what are the antiplatelets, what are their mechanism of action, and what is the dosing. So oral dose 150 to 325 mg is recommended for all patients, and then it acts by COX-1 enzyme inhibition, and then it inactivates the platelet aggregation. So the other antiplatelet that we use is either of these, either ticagrelor or prasugrel or clopidogrel. Before, during, what we have often used is clopidogrel, but nowadays, ticagrelor or prasugrel, if it is not available, only then clopidogrel is advocated. So we also use tirofiban if there is a patient who has unstable angina or a non-anesthesia elevation MI who is undergoing PCI. This will help in decreasing platelet aggregation. So this is the glycoprotein 2A 3B inhibitor. So percutaneous intervention, again, Dr. Suresh will be talking about it. So I need not go into details of it. So as I've already told, all the guidelines suggest door to balloon. There's something called as door to balloon time. So if we have a Cath Lab available, then the door to balloon time should be less than 90 minutes, which is the maximum. It need not be 90 minutes. If you have everything in, functional and is ready, you can, as soon as you get the ECG, which takes about 10 minutes, by the end of 10th minute, you can decide this patient would require PCI, and this patient will directly go to the Cath Lab, 10 to 15 minutes max. So what if there is no Cath Lab? Or Cath Lab is not functioning? What to do? We have another option, that is thrombolysis. You understood the pathophysiology of MI, right? There is a thrombus which is sitting in the coronary vessel, which is blocking the blood flow. Now, what you should do is, you should break it down. So if you break it down, the circulation will restart. So how to do it? We can use certain thrombolytic agents like tissue plasminogen activator like altiplase or tenecteplase or retiplase, or streptokinase or urokinase we can use. So these are the recommended this one. So even if there is no Cath Lab available, if you are working, for example, if you are working in a primary health center or not primary health center, in a taluk hospital or district hospital where there is no Cath Lab facility available, you can always start thrombolysis. These thrombolysis itself can decrease the mortality by up to 18%. So that is significant. So you don't have a facility, you can always utilize the thrombolysis. So what if we don't identify, we don't treat? What can happen? So as I've already told, these patients can go into dysrhythmia in no time. If there is a ST elevation MI, if the ischemia is ongoing, there is a cardiac muscle injury is already set in. So if we have not identified or the patients are presented very late, these patients can have dysrhythmias like atrial fibrillation or ventricular tachycardia, ventricular fibrillation, and further they can go into cardiac arrest. And if they survive, they can develop mechanical complications like ventricular free wall rupture or rupture of interventricular septum or papillary muscle rupture. All these complications can further complicate the entire issue, and then the patients can develop heart failure, and further, the long-standing the quality of life will come down. So these patients can go into heart failure, which is seen in about 15 to 20% patients. So that was about acute coronary syndrome. So I spoke about how the acute coronary syndrome patients present, what we do in the emergency, what are the investigations of choice initially that we do, how we look at ECG, how we interpret the ECG, and then how we activate the Cath Lab, and then how the patients are thrombolyzed, and what are the complications if we don't treat or identify the patients early. So now, similar, there is one more cardiac emergency, cardiovascular emergency, which can again be fatal if we don't identify. That is acute pulmonary embolism. So this is another condition which presents to the emergency very often. So what is this acute coronary embolism? Sorry, acute pulmonary thromboembolism. Acute pulmonary thromboembolism. What is it? Can anyone in the audience tell what do you understand by acute pulmonary thromboembolism? I think name itself is telling what is acute pulmonary thromboembolism. Anybody in the audience? Pulmonary artery. Wonderful. See, very nicely told. Very good. What's your name? It's okay. Okay. He doesn't want to be identified. So he rightly said there is an acute thrombus formation in the pulmonary artery. Thrombus, thromboembolism in the pulmonary artery. It's not the it doesn't generate in the pulmonary vessel. It generates somewhere else and then it gets into the pulmonary artery. So that is what it occludes the pulmonary artery and then it results in complications because of that. Okay. So you can see the diagram here, the picture. See, the usual origin for acute pulmonary thrombus in acute pulmonary thromboembolism is the deep veins in the leg. So you have undergone anatomy classes. Obviously, you know what are the deep veins in the leg, right? So these veins, if the patient has any issue with the leg, like cellulitis or any long-standing fracture, immobilization, such patients will have stasis of blood in the legs. So if there is a stasis of blood, so what happens? That results in thrombus formation. So when there is thrombus formation, these patients, if the clot moves upward into the iliac veins or to the inferior vena cava, so these patients, this thrombus will go into the right heart and then goes into the right ventricle, the right atrium and then right ventricle, which further enters into the pulmonary artery. Right? From the right ventricle, what is the outlet? What this one? It is pulmonary artery. So when the clot dislodges and then enters the pulmonary vessel, it can block anywhere in the pulmonary artery. Okay, it can be main pulmonary trunk or it can be either right or left pulmonary artery, or it can be subsegmental, any segment of the pulmonary artery, depending on the size of the thrombus. If it is huge, it can directly block the main pulmonary trunk. Usually, if there is a blockage of the main pulmonary trunk, there is no blood flow from the right side to the left side. So there is a blockage of blood flow from the right side to the left side. These patients will not even come to the emergency. The subset of patients who come to the emergency is if there is any blockage of one of the pulmonary arteries, or if there is a subsegmental pulmonary vessel block, such patients will come to the emergency. So here you can look at the pathophysiology. What happens when there is blockage of the pulmonary artery? When there is a blockage, what happens? There is a back pressure. The blood is the right ventricle is trying to pump the blood out, but because of obstruction, the right ventricle is unable to pump the blood out. So what happens? There is a right ventricular enlargement. So there is a back pressure onto the right atrium also. The entire right side of the heart will get enlarged. After some time, what happens is the right ventricle gives way. Okay, when the right ventricle gives way, it will not be able to pump the blood. So the left ventricular preload, that means the blood coming into the left ventricle will decrease, resulting in shock. Patient will develop hypotension. So this hypotension, along with the hypoxemia, will result in death. So this is something which is very fatal. So we should always identify such patients early, and then we should start treating such patients. So how do they present? These patients usually present with dyspnea, breathing difficulty, because there is hypoxia. The patients will have hypoxia because of shunting of blood. So there is a lot of hypoxia. These patients will have dyspnea, so shortness of breath, and then they also come with complaints of chest pain, which is usually sharp stabbing kind of pain, which worsens with inspiration. And also some patients also present with cough. So that is usually dry. It can be productive at times if it is blood. If it is long-standing, can be blood tinged also. So Okay, how do we diagnose? I have already told regarding pathophysiology. What happens when there is a the pulmonary thrombus which is blocking the pulmonary artery, which results in hypotension, and patients will have tachycardia, cyanosis secondary to hypoxia, and then if these patients, usually we should look at the source of the thrombus. I've already told it is usually the leg veins. It can be iliac veins also. If there is any pathology in the leg, like cellulitis, we should identify patients developing DVT. So DVT is one important aspect that we should always look at if the patient presents with shortness of breath, hypoxia, cyanosis, hypotension, tachycardia, all these things. We should look at if there is any unilateral leg swelling, or even if it is bilateral also, we should always look at this leg swelling. And these patients will also have raised JVP because of right atrial pressure, increase in right atrial pressure. The JVP will be elevated. So when we look at the clinical symptoms and signs, we definitely cannot assign everything to pulmonary embolism. There are possibility of other possibilities, right? If all the symptoms or clinical signs are present classical, then that is fine. You can definitely label it as pulmonary embolism. So for that reason, we always look at the risk scoring system. There are two important risk scoring systems that we utilize. That is, one is modified Wells score and revised Geneva score to identify if the patient has a P which is likely or unlikely. P is likely or unlikely. For that, we look at a few of the factors. I think it's beyond the class this one. So I'm not going to detail of it. So these are the risk stratification scoring system. This is another scoring system that we use in the emergency, that is pulmonary embolism severity index scoring system. This scoring system is utilized to predict the mortality. So if the PESI score is more than 125, you can see the mortality is as high as 25%. So we usually classify the mortality. We classify the PESI score and then look at the 30-day mortality risk of patient. So how do we evaluate these patients in the emergency? One is ECG. There are certain things that we do mandatorily in the emergency. If there's any chest symptom, it can be dyspnea, chest pain, or anything related to the chest, we always do an ECG. So here also we do an ECG. ECG, for UGIS, if you see the this one classical ECG that that is spoken in pulmonary embolism by this one, many of the consultants is S1 Q3 DP. That is, S wave is seen in prominent S wave is seen in the lead 1, and Q wave, prominent Q wave is seen in the lead 3, and T wave is inverted in lead 3. This is not always classical. It is just less than 10% of patients with pulmonary embolism such ECG changes can be seen. But still, if you see such changes, you should always, you should alert yourself that it can be a pulmonary embolism. We also get a chest X-ray if the patient has any of these symptoms. There are certain clinical signs that we look at. That is, on chest X-ray, you can see there is some oligemia, pulmonary oligemia. This is called as Westermarck sign, and the Hampton sum. You can see if there is a pulmonary vessel, occluded pulmonary vessel, what happens? The artery that supplies the part of the lung, if it is blocked, it causes wedge-shaped oligemia, ischemia of the pulmonary the tissue. So this results in oligemia. So this is a Hampton's hump. This again, it's not always seen. It is seen in only less than 5% of patients. So when we have a clinical suspicion, we do a D-dimer. So when we send a D-dimer is very highly sensitive, but it is very less specific. But we can rule out if the patient doesn't have a pulmonary embolism just by doing a D-dimer. See, if there is any patient who has chest discomfort and has a DVT, and then you send a D-dimer, if it is negative, that indicates the patient doesn't have a pulmonary embolism, or thromboembolic phenomenon is not it's not seen. So that is why D-dimer has a value of negative predictive value. If the patient doesn't have a pulmonary embolism, we can be sure of just by doing a D-dimer if it is negative. Then we also do a screening 2D echo, bedside screening 2D echo. If there is a pulmonary embolism, thromboembolism, as I've already told, there is right ventricular dilatation. So right ventricular dilatation, if the right ventricle starts failing, only the apex will be beating. This is called as McConnell sign. This is classical of pulmonary embolism. Here, I mean, in patients with, when you do a screening echo in massive pulmonary embolisms, we can see this McConnell sign. And also there is one more sign that we see on a 2D echo is D sign. This is again good identification for pulmonary embolism. It can also be seen in patients with pulmonary artery hypertension, severe PAH also. You can see this sort of D sign. So the gold standard investigation for any patient with suspicion of high suspicion of pulmonary embolism is CT pulmonary angiogram. So we can get the CT pulmonary angiogram as early as possible to look into if there is any thrombus. This is the heart from their right ventricle, from their pulmonary artery, pulmonary trunk. So this is the left pulmonary artery, and this is the right pulmonary artery. You can see the flow, the dye which is injected when we are doing a CTPA. There is flow on the left side, but right side it is restricted. So this indicates right main pulmonary artery blocked, thromboembolic phenomenon. We also, there are certain other investigations that can be done, scintigraphy and compression ultrasonography. So for DVT, we do a bedside ultrasound to look at the veins, the texture of the vein. If the vein is compressible, if there is any clot inside the vein, especially the popliteal vein and the femoral vein. At 3 different points we do to see if there is any thrombus. So that also can help in differentiating or diagnosing DVT. So when diagnostic workup, how we do is, if the patient is hemodynamically unstable, if the patient presents with hypotension, tachycardia, such patients should not go any other investigations, undergo any other investigations. Such patients should be subjected for CTPA. If CTPA is negative, then if CTPA is positive, patient should be treated as pulmonary embolism. If it is negative, you have to search for other causes of shock. And if the patient doesn't have a hemodynamic instability, then we should do a D-dimer test. D-dimer, if it is negative, again rules out. If it is positive, then these patients again should go undergo CTPA. So how we manage such patients in emergencies? We start on anticoagulants, unfractionated heparin or low molecular heparins. We start unfractionated heparin, like which is I think the mechanism of action is it binds and activates the factor antithrombin 3, and which inactivates thrombin, which is factor 2 and factor 10A. So thus results in the clot. At least it decreases the clot formation. Thrombogenic phenomenon is inhibited. So we also start on thrombolysis, systemic fibrinolysis, by using altiplase or tenecteplase, that is RTPS, and streptokinase. And the use of Cath Lab, to emphasize again, in these patients also, the Cath Lab intervention can definitely help the patient for quicker relief in clinical signs and symptoms, and these patients can survive for long. So if there is something called as catheter-directed thrombolysis that can be done, mechanical thrombectomy and aspiration thrombectomy can be done in the Cath Lab. So outcome, if patients are not identified or treated, mortality is as high as 40 to 50%, especially in high-risk patients, and right heart failure, which can be prolonged, and then patients can develop pulmonary hypertension, which can result in long-standing sequelae because of the pulmonary hypertension. So other complications are pulmonary infarction, increased risk of future thromboembolism. So that was about the cardiovascular complications secondary to either ACS or acute thromboembolism. There is one more entity called as acute limb ischemia. Similar to what we spoke about, the blood circulation, if it decreases in any part of the lung or the heart, there can be complications. Similarly, any part of the leg or limb, any of upper limb or lower limb, that can result in complications. So that is called as acute limb ischemia. So here, what the patients usually present with, suddenly if there is a blockage of the blood, especially the artery, if there is a blockage, in the upper limb or lower limb, what happens? The circulation to the periphery is decreased. So when there is a decreased circulation into the periphery, so there can be muscle injury because of ischemia, and then there can be nerve injury also. These patients can result in major complications, and then they can lose the limb. So we have to identify such patients again early. So these patients will present with affected limb pain, and they can have tingling, numbness, or numbness of the affected limb, and also because of muscle injury, the patients can develop, come up with muscle weakness also. So risk factors like peripheral vascular disease, if there is any recent trauma, surgery, all these things are risk factors which will result in acute limb ischemia. So such things the patients present with. So clinical diagnosis is we look at 6 P's, that is pain, paralysis, paresthesia, pulselessness, pallor, perishingly cold periphery. All these things are clinical signs of acute limb ischemia. So once we are sure that there is acute limb ischemia, so we go ahead with further evaluation. Ankle brachial index is one of the useful indicator in emergency to look at how bad the limb is, whether the patient limb is salvageable or not. Because if there is if the systolic blood pressure measured in the upper limb, brachial and the ankle, if it is significantly high, that is more than 0.4, that indicates the limb ischemia significant. These patients, the salvaging limb will be difficult. This is the arterial Doppler that we do on bedside, so that to determine if there is any blockage of the blood vessel. Okay, a certain classification that we use in the emergency. So the treatment of choice in these patients again is revascularization. The use of thrombolytics or anticoagulants is not that much. We definitely use it for to decrease further thromboembolic, thrombus generation, to decrease the thrombus generation. But ideally, these patients should undergo revascularization. That is the treatment of choice. So how revascularization is done? Just like how the coronary revascularization is done, going to the affected place and then the affected site, and then dilating the vessel by using the stent. So this, if time permits, Dr. Suresh might speak. So if not treated, amputation, these patients can go into gangrene, necrosis, and if further complications because of infection, sepsis, and permanent neurological damage, and mortality can be as high as 25 to 30%. So to conclude, as first responders in the emergency department, it is important for us to identify what are the gravest or fatal acute acute events, cardiovascular events that come to the emergency. We should identify early, and then we should alert the interventional cardiologist as early as possible, so that we can seek their help and make sure that the patient survives the acute event. So timely intervention is the what is required in the emergency. So my references are this, and thank you.
Any questions from the audience? No questions. I thank Dr. Deepak sir for his insightful presentation. Sir has spoken in detail about what are the most commonly encountered cardiovascular emergencies in the emergency department. I'm sure his expertise has benefited most of the audience present here. I now invite our next speaker, Dr. Naveen, Professor, Department of General Medicine, to speak on cardiovascular risk factors, primary and secondary management. Over to you.
Thank you, Rupashni. Yes. Today I'm going to talk about the cardiovascular risk factors, primary and the secondary management. Why we are talking about this topic today? Because of this. You can see the first few lines. The most common cause of the mortality even today is the first thing is ischemic heart disease followed by a stroke. Both are same, vascular in etiology. Almost both of them will share the same risk factors. Both. Right? Suppose if you want to reduce these two most common cause of mortality you have to reduce. What you have to do? You have to reduce the risk factors, right? First, the most common thing is we have to screen for the risk factors among the who are the vulnerable population. We have to screen them, and we have to identify which is the risk factor which is leading to the these two vascular events, and if we can able to treat early, so that we can able to prevent these deaths, right? Yes, you can see the data here. In 2019, ISD alone claimed approximately 1.5 million deaths in India. It is around 109.2 deaths per 1 lakh population. Between 2009 and 2019, deaths due to ISD has been increased significantly because of the increase in the risk factors associated with the ISD. This is the various level of prevention. Primordial prevention is the prevention of the development of risk factors. In this one, we can't do much here because this is usually done by policymakers, right? Primary prevention, actually, this we can do in a better way. Means what? We have to, prevention is before the occurrence of any evidence of a cardiovascular disease, that is called as primary management of primary prevention. Secondary prevention, already patient has got a cardiovascular disease. Yes. You can see this is the pyramid. Means what? We have to avoid this one, the topmost triangle, that you have to avoid. How to avoid this one? If we can able to treat effectively the risk factors thoroughly, then only we can able to avoid this figure. Means why you have to avoid this one? Because India is still a developing country, right? The economic crisis, because no, if we want to, all the patients who I want to treat here, no, the economic burden will be more on the patients, right? Even the scarcity of the specialist, you can tell specialist, because no, in India still they don't have a specialist center everywhere. Even in the whole Tumkur district, even in Tumkur is only Tumkur is available, all the cardiologists available, right? Just of the taluka as well as in the oblis, no specialists are available. But if we can able to identify all the risk factors and treat effectively, so that we can able to prevent the mortality as well as the morbidity associated with the cardiovascular disease. So this is the risk factors. Among them, it is divided into the non-modifiable and modifiable. Non-modifiable means we cannot change anything in this one, like our parents, age, we cannot change like that, right? Non-modifiable, age, gender, ethnicity, as well as the family history, we cannot change. Modifiable, in the same order, the risk factors will be there, right? Like first thing is the hypertension, most common risk factor, followed by hyperlipidemia, diabetes, obesity, smoking, poor diet, sedentary lifestyle, followed by stress. First, we'll talk about the age. As the age increases, definitely for everyone, the cardiovascular disease will keep on increasing, right? Men and women after the age of 40 years, the age of getting a coronary disease increases by 49% as well as 13% respectively. You can see as the age increases, the cardiovascular mortality also increases. But this has been intervened by various modifiable risk factors, right? If you won't get these modifiable risk factors, otherwise this will have a linear relationship. Yes, gender. Men are at the increased risk than compared to a woman of getting a coronary artery disease. Women will have a 7 to 10 times lesser chance of getting a coronary disease than compared to a men. Then men are more likely around 3 to 4 times than women who suffer from a ST segment and the non-ST segment elevation MI. But this scenario has been changing. Why we are changing? Because even the previous in women also few risk factors has been keep on adding because of the our lifestyle, because of the education, because of the availability going for a work, stressful environment. This has keep on being changing. Even among the young adults, you can see premature menarche, right, and polycystic ovarian disease, as well as some other connective tissue disorders. In the young adult, in the childbearing age, because of the pregnancy-induced hypertension, GDM, right, so many pregnancy loss, infertility, going for a IVF, the risk will increase. Even in the late adulthood, even the premature ovarian failure, as well as the premature menopause, these are the risk which has been increasing among the women. Because of this one, the risk of the getting cardiovascular has been increased than compared to routine risk. Ethnicity. As a South Asians, we belong to we Indians, we belong to a South Asians. Than compared to globally, South Asians will have a higher risk, around 4 times more likelier than getting a cardiovascular than compared to general. Why? Because of our build. What is that build is? Our central adiposities. Means what? We keep on accumulating fat in the around the abdomen as well as in the buttocks. This will increase the chance of getting a coronary artery disease. That's why we are a little bit prone. So heart disease presents in South Asians even among younger age 5 to 10 years early than compared to other groups because of the build. Coming to the family history. What is the significance of family history in the coronary artery diseases? One is the premature coronary artery disease. We always ask among the patients if any of your first degree relatives, like parents especially, first degree relatives, my father, mother, or your brothers, and anyone is having a premature coronary artery. What is that premature? Means what? Anyone getting a coronary artery disease among men less than 45 years, among women less than 55 years is having anyone using a cardiovascular disease. If it is there, the chances of getting a even to the affected patients will be very high. Why? Because of usually in these cases it will be familial hypercholesterolemia will be there. That's the reason. So World Health Federation has adopted mission 2525. What is this 2525? They want to reduce the premature deaths by 25% by the age of 25. How we can be able to achieve? By improving the 6 preventable factors. First, they want to tobacco and alcohol has to be quitted. Reduce the salt intake to less than 2.3 grams per day. Maintain the BMI of less than 25 and keep the blood pressure to the target less than 130/80 and keep the HbA1c under control. These are the 6 preventable factors to achieve this mission 2025. The World Health Federation has been adopted. Hypertension. When to tell hypertension? If the patient is having a BP of more than 140/90 or equal to 140/90 on more than 2 different occasions, means usually around 15 days to 1 month gap, then we will tell that if it is rise, then we will tell patient is having a hypertension. Hypertension, you can think that this is one of the most common modifiable risk factor. If we combine both hypertension and smoking together, right, that is the most common, majority of the diseases getting cardiovascular disease because of the hypertension and smoking. If we can avoid these two drugs, otherwise we can able to control these two, the modifiable risk factors, we can able to prevent around 25 to 30% of the cardiovascular death can be prevented with these two risk factors. How this hypertension will have a coronary artery disease means because of the oxidative as well as the mechanical stress it places on the arterial wall. The meta-analysis has been revealed that even by just reducing the systolic pressure by 20 and reducing the diastolic pressure by 10, we can able to reduce the coronary artery disease by 50% between the age of 40 to 49 and roughly around 30% between the age of 80 to 89 years. How we can able to, what are the predominant driver for this hypertension is, one is the behavioral changes, especially the diet. Means what diet? High salt diet, consuming low fruits as well as vegetables, and the physical inactivity and overweight and obesity. These are the most common drivers for this hypertension. How we manage hypertension? Means primary management. Means what? If the patient is having without any coronary artery disease is there, then our target is just to control the blood pressure is enough with the various available medications, starting from the calcium channel blockers, ACE inhibitors, ARBs, beta blockers. Many drugs we can able to start. Only our target is just to control the blood pressure. Based upon his comorbidities, we can able to select. But secondary management is what? If the patient is already having a coronary artery disease, then what? Here the controlling the blood pressure is very important with the help of available drugs. Means what? There's a compelling indication that we have to start him on the ACM inhibitors. If there is a contraindication for ACE inhibitors, like any hyperkalemia is there or any patient is having a ESRD, then you can able to then it is contraindicated, then you should not give these ACE inhibitors or ARBs. Then beta blockers means what? Any patient is having coronary artery disease, these two are a must drug we have to start, and we have to maintain the blood pressure less than 130/80. That is the target. not like a reducing the 140/90. You have to keep the blood pressure target of less than 130/80. Hyperlipidemia. I didn't mention it is a dyslipidemia, it is hyperlipidemia. Why? Because so many things I'll tell later. This is the most common second preventable or modifiable risk factor in the patients with the coronary artery disease. According to World Health Organization, raised cholesterol causes estimated deaths around 2.6 million every year. These are the various lipid profile components. When we order a fasting lipid profile, right? These are the various components it will reflect. Among these, so many things will be there, but we'll mostly concentrate on the LDL cholesterol, right? This is because this is the main drive for your atherosclerosis. Main drive. First thing target is our LDL cholesterol. Once this target has been achieved, then we'll move on to the other targets like total cholesterol, HDL, triglycerides, right? So for our discussion, it is mainly our target is LDL cholesterol. And early 1994 review that 10% reduction in serum cholesterol, you can able to reduce 50% of the coronary disease at the age of 20, and 40% reduction of coronary disease at the age of 50, and 30% of coronary disease risk at the age of 60, and 20% at the age of 70 years. So our goal is just to control the LDL cholesterol to reduce the atherosclerotic burden. Primary management means what? The patient has not got still a coronary artery disease per se. So during that time, when we start the anti-cholesterol treatment, only when the LDL cholesterol is more than or equal to 190 milligram per dl, then only we start him on the treatment. What treatment usually will start is, usually we start with the statins, either atorvastatin or rosuvastatin, right? Non-statin groups are there, like ezetimibe is there, bempedoic acid is there, nicotinamide is there, even the PCSK9 inhibitors are there. It has been injectable, recently has been started. But usually, primary management, usually patient can be controlled with the statin group alone. Only the patients with who have a diabetes, for them, even we can start the treatment treating the LDL cholesterol even the less than 190. Means what? Even if the patient is having a diabetes, LDL cholesterol between 70 to 89, 189, we can start him on the statin to reduce the atherosclerotic burden. What is secondary management? Means what? Now the secondary management is patient is already got some coronary artery disease is there. In this patient, we without even the checking for LDL cholesterol, we will start him on the statins. Means what is our goal is to reduce the 50% of the baseline reduction of the LDL cholesterol we have to reduce. This is a slide showing that any patient who is having a hyperlipidemia dyslipidemia, we will calculate the atherosclerotic cardiovascular score. That we will tell is a 10-year atherosclerotic cardiovascular disease score. What is the 10 years means what? We will start predicting in a future 10 years how much of chance of getting a coronary artery disease. That is what is the in future 10 years how much risk of getting a atherosclerotic disease. That's what we will calculate for all the patients who is having a dyslipidemia. Among them, we will grade like whether the atherosclerotic burden is a very low, borderline, intermediate, and high based upon the percentage. You can see percentage 5, 75, 7.5, 20%. If the atherosclerotic 10 years atherosclerotic cardiovascular risk is less than 5%, for these patients, usually we won't start him on the any statin therapy. Usually only the lifestyle therapy is enough for them, right? If the atherosclerotic cardiovascular risk is between the 5 to 7%, for them we can start him on the low dose of statins we can able to start. If the risk is between 7.5 to 20%, then we can start moderate to intensity of statins we will start. And if the risk is more than 20%, you have to start him on the high intensity statins, right? So this is based upon the 10 years cardiovascular disease risk. Until before, sir, I told that when to start the statin and how much, what is the LDL we have to start. But in the left side, you can see that one, how much is the target LDL based upon the atherosclerotic burden. If it is the very low risk is there, even less than LDL target is our less than 100. If the atherosclerotic burden is moderate to high, we have to reduce the LDL cholesterol to less than 90 to less than 70. If extremely and very high risk is there, then even if we reduce the LDL to less than 55, nowadays we can even go less than 40 also is acceptable. So this is our target LDL. Then moving on to the next, that is the diabetes. Within a short time, India is becoming a diabetic capital of the whole world because of the so much of increase in the diabetic prevalence. Any patient who is having a diabetes, no, heart disease is 2.5 times higher in men and 2.5 times higher in women than compared to patients who is not having a diabetes. This is a diagnostic criteria to diagnose the diabetes mellitus. If the fasting plasma glucose is more than or equal to 126 or 2-hour postprandial after 75 gram glucose OGTT, if it is more than or equal to 200, told you have a diabetes, or random blood sugar more than or equal to 200 plus the classical symptoms of hyperglycemia should be there, polyuria, polyphagia, or catabolic symptoms, or HbA1c more than or equal to 6.5%. Here you can see that it is a RRR written, not unwritten. So even any one is enough to tell the patient is having a diabetes. What is the most 4 important pillars in the diabetic treatment is? First thing is diet, second thing is exercise, third one is medication, and fourth is monitoring. Monitoring means not only the sugar monitoring as well as the monitoring of all the complications. That is also one of the, even the diabetic treatment only it is there, because you have to modify treatment based upon the monitoring. What is the primary management? Means what? The patient is not having a coronary artery disease. Here our main target is the glycemic target. With whatever the available anti-diabetic medication is there, with that one we have to reduce the HbA1c to less than 7%. Right? That is our main aim, especially primary management, and prevent the diabetic related complications. Here now, in the primary management, all diabetic medications is open now. Means what? Any diabetic, starting from the biguanide metformin you can use, or sulfonylureas, or the DPP4 inhibitors, or SGLT2 inhibitors, GLP analogs. Any drugs you can use based upon the patient comorbidities as well as the patient profile we will use just to reduce the glycemic burden. Right? Various meta-analysis has been shown that the persons whose HbA1c is very well controlled, less than 7% majority of the time, the chance of getting a coronary artery disease is much less than the person whose HbA1c is more than 7, most of the time getting a coronary artery disease. Secondary prevention means what? Now the secondary prevention means already patient is having a coronary artery disease. Here the glycemic management is only not important. Even the agents what we use to reduce this coronary artery disease is also important, like SGLT2 inhibitors or GLP analogs. These two are the drugs which has been proven beyond doubt that it will reduce our cardiovascular disease burden. So any person diabetes is there who is having a atherosclerotic cardiovascular disease or a coronary artery disease or even the cerebral vascular disease, there is a compelling indication that you have to start him on the SGLT inhibitors or a GLP analogs. What are these SGLT inhibitors? It's what I told: dapagliflozin, empagliflozin, canagliflozin. These are the SGLT inhibitors. GLP analogs, because still it is not there in Indian market because of the huge demand in the US. Still we are getting a semaglutide here, right, orally. Rest of the other things are there injectables, like liraglutide. Even the injectable semaglutide will come, exenatide, like that. So along with the glycemic management with the GLP analogs and the SGLT inhibitors, the blood pressure management is also important in a patients with the diabetes and the coronary artery disease. And even the lipid management is also important. These are called as 4 pillars in the management of diabetes with the coronary artery disease. So that's what I told. Compelling indication of SGLT inhibitors and the GLP analogs in a patient who is having a diabetes as well as the cardiovascular disease. Coming to the obesity. Any person who gains the excess of weight, they keep on traveling near to the coronary artery disease. There is the meaning here. So this is the normal basal body, that is the body mass index will calculate. That is the in the denominator will calculate the height in meter square. In the numerator will calculate the weight in body kg. Then you will calculate the BMI. Healthy normal is 18.5 to 24.9. That is for the rest of the world, not for the South Asians. As I told, South Asians we are different. So we cannot still calculate the same BMI to calculate the obesity, because our body mass index, even at 20, if you maintain the 25, if you maintain the around by BMI around 24.9 or 25, our risk of getting a cardiovascular disease is very high than compared to the other. So they reduced this BMI as 18.5 to 23 as a normal for the South Asians, means Indians. Overweight 23 to 27.5 for the South Asians, and obesity will tell more than or equal to 27.5, we tell it is a obesity. Because BMI is not correlating to the coronary artery disease, especially in South Asians, we introduced the newer, that is the waist hip ratio. This is the better marker than body mass index, especially for the South Asians, for predicting a coronary artery disease. We'll calculate the waist. Where is the waist is? It is the midway between the lower end of the rib cage as well as the iliac crest. That is midway is called as waist. Hip is the most prominent part of the buttocks, is called as the hip. We'll calculate the ratio, right? The healthy ratio is 0.9 or less, it's called for men, and 0.83 to 85 for women, it is called as normal. We'll define central obesity when the waist circumference is more than 102 centimeters in men and more than 88 centimeters in women. It is called as central obesity. This is more predictable for the cardiovascular disease, especially for South Asians. Obesity is not only an independent risk factor for the coronary artery disease, it also increases the risk of developing other coronary artery disease risk factors like hypertension, hyperlipidemia, as well as the diabetes. Obese patients are twice likely to have a coronary artery disease after adjusting for a demographic profile as well as the smoking, physical activity, and the alcohol intake. The chance of getting a coronary artery disease is high. In 1998 research study and the 2016 review article confirmed that obesity is very complex, not like a routine. You can see it is very complex and a high grade atherosclerotic coronary artery lesions than compared to simple lesions. Primary management, that's why I told only the left modification is there. Secondary management means what? Any person who is already having a coronary artery disease, right? Along with the lifestyle modification, we have to undergo pharmacological treatment, right? But whenever you are selecting a pharmacological treatment for a obesity, here we are looking for even for a whether definitely that drugs are cardiac safe or not. Like routinely we use the obesity naltrexone, bupropion, other sympathomimetic drugs like phentermine, right? This cannot be used because it's still cardiovascular safety has been not well proven. If you want to select a drugs for obesity, then you can go for a GLP receptor antagonist, right? These are well studied. Even the many trials are on the way. Next in future, I think in another 4 to 5 years, no, these are the main drugs for obesity. We can come into the picture. These are at present still liraglutide and tirzepatide injectables are available, but semaglutide is there. No, this is still oral. It is available, but presently using this one as an anti-diabetic drug. But this has been studied well on cardiac safe drug also. Better to avoid the above sympathomimetic and the naltrexone group, better to avoid. What is severe obesity? BMI is more than or equal to 40. It's called as severe obesity. In these patients, along with the weight-related comorbidity, we have to go for some surgical procedures to have a better benefit. Like bariatric surgery, that is gastric bypass, it's better to undergo. Smoking. smoking means what? Nowadays, no smoking, not only the classical tobacco smoking is called as a smoking. Even nowadays, e-cigarettes has been came. E-cigarettes in that one, various things are flavored come is there, watermelon flavor, orange flavor, right? Many flavors has been there. Along with that one, even the nicotinic and non-nicotinic has been there. Actually, first e-cigarette came to the market in such a way that the person can be withdrawn from the classical nicotine smoking. To withdraw, they started using a e-cigarette. But within a short time after releasing e-cigarette, even the school children, they started e-cigarettes. They think that it is a not harmful. So it is not proven its benefit. But in the Western market, it has been so much boom is there. Now they most of them preferring the e-cigarettes. But this even e-cigarettes are banned because it is also showing a increased risk similar to a tobacco smoking. Tobacco smoking has resulted in a twice the risk of cardiovascular disease for current smoker and 37% increase in the risk with the former smokers among patients with more than 60 years of old. Non-smokers, even your friend are smoking is enough. If you are bearing it with him for a 24/7 is enough. You are also at a higher risk. But not as much as, but definitely your risk also will be increased. How this smoking will induce a coronary artery disease? Smoking induces elevation in the blood pressure and the vascular tone, and it causes a coronary vasospasm and lowers the arrhythmic thresholds, impairs the endothelium dependent vasodilatation. It is a sympathetic pro-inflammatory effects, and it causes a spontaneous platelet aggregations in the coronary artery disease and reduces the fibrinolytic action and augments the insulin resistance. This is the various mechanism it will causes the mismatch. So the risk of coronary artery drops to a level of a lifetime of a non-smoker with the help of a 4 years of quitting. Means what? Once the person left the smoking for 4 years, it almost, especially coronary artery risk will drops to a almost like a non-smoker. It will drop, but not the risk of a cancer, not a risk of a COPD. Only the coronary artery disease will drop. Rest of the cancer, COPD, everything almost remains the same. Primary and the secondary management means what? First, usually the behavior interventions will give. Like first, you will ask the patient, then you will advise, then you will assess, then you will assist, and arrange for a follow-up. But majority of the times, it will be the chance of quitting will increase only if you done a pharmacological interventions. Like nicotinic patches will come, nicotinic gums will come, nicotinic lozenges are there, even the nicotine sprays are there, right? Even the nicotine inhalers are there nowadays, right? As well as penicillin, bupropion, you can able to reduce. If you can able to combine the both behavior interventions as well as the pharmacology, the chance of quitting of the tobacco will be very high. Even recently, our college also has opened tobacco cessation center in the ground floor recently with the help of a psychiatrist. So poor diet. What is mean by poor diet? So any person who is consuming more than 10% of the required calories with the help of saturated fatty acids, right? And consuming a refined sugars more. What is refined sugar? It is called as a new heroin. Refined sugars, because no, previously we were telling that only the person is taking heroin as a very bad habit. The chance of getting a coronary spasms are very high. Mortality will increase. Nowadays, no, because no availability of the Coca-Cola, Pepsi, everything. Even you can see in our routine. Once the 12 o'clock, when clinics has been closed, everyone will go to the canteen. They want to drink one thumbs up and they want to move to the next class. They were addicted. Many times we asked, hey, why when you are drinking? No, sir. If I won't drink, I'll get a headache. Yeah, many persons will tell, because so much addiction is there. That much at that time they want that glucose load, right? So then, fasting saturated acid, saturated fatty acid, as well as the glucose, as well as the trans fats. These are the main food diet, whatever is there. Is there any diet, specific diet, which is very good for a cardiovascular health? Is vegetarian diet, right? So even the many guidelines that you have to go with the Mediterranean type of dietary plan with higher intake of plant-based food and the lean protein with lower quantities of saturated fat, which is helpful to reduce the cardiovascular risk factors. So Mediterranean diet for a cardiovascular health. This is the most common diet we will advise. So in 2017, narrative review has been revealed that a decrease in the cardiovascular risk by about 20 to 25% with the vegetarian diet alone, and it showed that positive effects on the endothelial function, arterial stiffness, as well as the cardiac function. So the association between the saturated fatty acid and the coronary disease has been very much proven. So we have to reduce the saturated food acids. There is an emphasis on the re-emergence of refined sugars as a main risk factors recent days. And the trans fat. How we are getting a trans fat? Mainly with the help of a fried items. Like any fried item, chips, everything. From there only we are getting an increase in trans fat. So trans fat increases the risk of cardiovascular disease through the adverse effects on the lipids, endothelial function, and the insulin resistance and inflammation. Every 2% of the calories consumed from the trans fat was associated with a 23% higher CAD risk. So AH and ACC guidelines recommend that a diet consuming mostly vegetables, fruits, legumes, nuts, whole grains, and the fish. Dietary intake of processed meats, refined carbohydrates, sweetened beverages should be reduced while avoiding the trans fats altogether. Saturated fat should be replaced with the poly or monosaturated fatty acids. Better. So this is the ACC. In the box they given, you have to avoid trans fat like baked foods and the fried foods you have to avoid. Instead of this, we can go for a vegetables, fruits, and the whole grains you have to consume, lean proteins, complex carbohydrates, dietary fibers, or monounsaturated fatty acids, as well as the polyunsaturated you can able to choose. And you have to avoid the saturated fats, dietary sodium, and the processed meat you have to avoid. So what is sedentary lifestyle? This is the definition of the what is meant by sedentary behavior. It has been defined as any waking behavior such as sitting or leaning with the energy expenditure of less than or equal to 1.5 metabolic equivalent task is called as sedentary behavior. Nowadays, 1/3 of the global population aged 15 years or older engages in insufficient physical activities. So sitting time is directly proportional to the all-cause mortality, right? Exercise is a protective factor in preventing the development of coronary artery disease. What is the mechanism of this sedentary lifestyle and the increased risk of coronary diseases? Through the enhanced endothelial nitric oxide production and more effective reactive oxygen species deactivation and the improved vasculogenesis. So what is the solution? Only thing is we have to tell that even 150 minutes per week of moderate intensity aerobic activity is enough to reduce the risk of coronary disease, right? What is meant by moderate intensity means its heart rate has to increase by 50 to 70%. That is the moderate aerobic exercise. But when you are giving a secondary management, especially in a patient with a coronary disease, no, we cannot advise the same exercise for a coronary artery disease because the patient is already in a failure. Suppose if we tell him to do moderate activities, the patient may not come from the exercise. So to conclude this section, AH has given simple rule. That is a AHS Life Simple 7. What is that simple 7? Get active. What is that getting active? More than or equal to 150 minutes per week. Moderate intensity of aerobic exercise is needed. Eat better and lose weight. Stop smoking. Control cholesterol. Keep the LDL to the target and keep the blood pressure less than 180, 130 by 80. With the available medication, use ACE inhibitors and ERBs and beta blockers whenever possible and keep the HbA1c to the target. So thank you.
Any questions?
Sir, the oils keep on changing, sir. Nowadays, olive oil has been started. You are talking about 2 years back, rice bran oil they are talking. Now the olive oil has came. Because of the increased availability of the polyunsaturated and the monounsaturated fatty acid is very then white bran oil. It is preferred, sir. Compared to the refined sunflower, it is better. White bran.
Good morning, everyone. Regarding oils, what we know is the chemical composition of oil we know, and what is the implication of that we know. But coming to the population long-term study, we don't have a data. And second thing is we don't have a uniform cohort to analyze whether this oil is good or this oil is bad. So it's all anecdotal studies and anecdotal opinions. So whatever is preferred, you prefer.
Any other questions? Thank you so much, sir, for giving such a comprehensive presentation on cardiovascular risk factors, primary and secondary management. Whatever the information you shared is undoubtedly it is going to help us in making informed decisions and implementing the effective strategies for primary and secondary management of cardiovascular risk factors. Thank you so much, sir, for your valuable time. So the two sessions are over. So shortly we'll have a inaugural program. I request everyone to be seated. So students,
request all the students to be seated. Nobody should be moving around when the guests arrive. And please keep your phones in silent. Maintain the decorum of the inaugural program. Thank you.
Dani